Assalamu alaikum. Good evening, everyone. Welcome to our webinar for today. My name is Ala Al-Umari, Patient Safety Specialist in Saudi Patient Safety Center, and I will be responsible for hosting this webinar. Today's sessions will last for 60 minutes. Before we get started, I would like to go over a few tips so you know how to participate in our webinar today. You will have the opportunity to submit text question through the Q&A icon in the control panel. You can submit your question at any time during the presentation, and we will collect and answer them at the end of this session. Our presenter today is Dr. Amani Bahdela. She will be present to us the topic high-risk situation in medical treatment. She is a senior clinical pharmacist who worked in the field of pharmaceutical care services through many managerial positions since 1996. Her practice mainly was in a sterile IV admixture, pharmacy section, parenteral nutrition, clinical management, and oncology, hematology, chemotherapy pharmacies. So she worked as a Sibahi surveyor for 3 years. She had her bachelor degree in pharmacy science from King Saud University in Riyadh. Also, her master's degree specialized in clinical pharmacy and leadership in healthcare management as an executive education program from Harvard Medical School in March 2019. Dr. Amani is the director of Health Education and Promotion Department for the past 3 years at King Abdullah bin Abdulaziz University Hospital. Now I would like to welcome our speaker and we will start our session. Dr. Amani.
Thank you, Dr. Ala. Welcome everyone, and thank you for inviting me. I appreciate really from the Center of Patient Safety. Really, I appreciate being with you as a member and to present today many issues that is really affecting the patient safety, and together with the measures that it's really updated for the meantime to cover the patient safety topic through the appropriate medication management procedures. Actually, we will start now by doing an outline of quality standards and regulations. We will do a kind of an overview on staffing responsibilities in healthcare as a healthcare providers, criteria of patient care as an inpatient, in the inpatient pharmacy specifically due to medication management procedures, continuity of practice, the good practice versus malpractice, the communication that it's really is the patient safety and can be very challenging during the health field, the discipline and the risk management in patient care, and the importance of reporting and documentation. My presentation, it's going to be not more than 60 minutes, including the questions, and I might stop for a while to ask some questions. Appreciate your attention, and if you do have any question, we do have our moderator. You can ask in the chat, and everything is going to be settled. And I will answer all the questions at the end of this webinar. Thank you again, and we'll start. Usually, the Joint Commission standards and medication management is one of the regulations in the whole world, specifically the field of medication management, because they did manage to do many societies to help medication management and to help the patient safety as a whole from different fields and different situations. We do have the societies from the Joint Commission, like the International Patient Safety Goals Society, and there is another society, there are a total of 8, the Access to Care and Continuity of Care, and the Patient and Family Rights, which is really very famous society that we are following. Also, there is a society known as the Assessment of Patients and the Care of Patients, even the anesthesia and surgical care. And there is another society with the same terms, ASC, which is Ambulatory and Surgical Centers. Also, the most famous chapter, Medication Management and Use chapter. We use this chapter usually in the board of Saudi accreditation SIBAHI. This chapter has 522 elements that it's following the criteria of the quality management and to do the proper management of medication towards patient safety. Also, the chapter the Society of Patient and Family Education. We do have an organizations that it's really covering those quality standards, and the Joint Commission also is the pioneer in those organization management. They are the quality improvement and patient safety, prevention and control of infections, governors, leadership and direction, facility management and safety, staff qualification and education, and management of information. All of those are related directly to medication management and patient safety. So if we follow the cycle of each medication that comes to our hospital, we will start from procuring of medication. From the procurement, أمور الشراء for any medication, it really needs some time to get the medication with a specific financial steps. Then we'll go for storing the medication. So we have a standards of storage for each medication, with whether it's refrigerated, whether it's room temperature, whether it's a chemotherapy versus regular medication. And the regular thing that's supposed to be the cabinet itself and the way to open the boxes and to put on shelves. Then we will order and prescribe those medication. Then we start to do transcribing. The word transcribing means that we take all the information and we do a proper verification for the orders to translate, transcribing coming from translate the words of the physician, the order of the physician into medication. And it's supposed to be with many details of dispensing, many details of preparation, many details of the volume, and all the things that's supposed to be. Then after we take the transcribing, we start to distribute the proper medication for the proper section in pharmacy. So if it's an oral, we will just give it to the unit dose system. If it's an IV, we will give it to the IV room. If it's a chemo, we'll give it to the oncology pharmacy, and so on. And then start to prepare the medication upon its standards of preparation technique, and we have a proper label that it's done that represents. And I will talk about the legal label that could prevent any mistake that could happen and ease the information to be delivered to the nursing, so they can do a proper administration to avoid any mistakes or any errors. And we will talk even about the medication error instead. And then after preparing for dispensing, then administering by nursing, then documenting in the MAR, which is the administration record, whether the medication given and what's the volume and what's the timing of giving. And then lastly, we will just go for monitoring the medication and the patient, whether there is a side effect, there is toxicity levels, and so on. So the cycle is really a closed loop that we suppose always to look for the proper medication management and the steps through those cycle, through those steps. So assure patient safety, we should maintain the quality measures in patient care. And that's why these quality measures is not coming haphazardly. We supposed to follow standards of guidelines, which they are the proper guidelines followed internationally by all means. And even though we have to make sure that we have a 0% of errors towards patient whenever he is treated and get the best result of patient. So I know it's a difficult thing. Sometimes it seems to be difficult, but if it's well enrolled and well developed and well implemented inside the hospital, inside the healthcare institute, it will give a very good patient care. But we have to follow the following. We have to do the right thing at the right time, in the right way, for the right patient. These are the right thing means the procedure that's supposed to be. The right time means we need to save the patient if the patient is sick. In the right way means we should have the qualified people to do the proper thing with the specialization, with the professionality. For the right patient means we should do a proper review for the patient just to avoid any mistakes that could happen or errors in these steps. But these are a thing that it's talking about the whole procedure. There is another thing talks about the medication management, patient rights, where we will discuss it later on, the patient rights. So after this, the quality was supposed to be applied in the proper way to give the best possible results for the patient. So commitment from pharmacist who's taking care of the medication, because the pharmacist is the medication manager who's always giving a review and giving a study. So in pharmacy, we do have many sections, but the inpatient pharmacy by itself, it has a high standard of double checking, high standard of care, high standard of applying the rules and regulations, because it's a high risk medication. The high risk medication is not the word risk. We're just giving this risk to make it more easier to understand. But what we usually say, the medication in the inpatient pharmacy, because most of them, they are IV, they are intramuscular, they are subcutaneous, cartridge, mostly biological agents. Those are high alert medication, including the inotropes and emergency medication. So the high alert medication, they do have a narrow therapeutic index. They do have a very narrow angle between the therapeutic effect and the toxic effect. We should always have this kind of good monitoring to give a good efficacy and avoid the toxicity of those high alert medication with a good applying of the in practice and good follow-up. So the medication safety is our concern. Our staff, usually in the hospital and health system, the medication used in this hospital system as highly complex, and they do have several steps to be followed. That's why errors can happen due to these steps between verification, transcribing, preparation, distribution, dispensing, and then administration, and then following up. So in these steps, we should go and just check where can the patient harm happen? Where can the error happen? In the inpatient department, they found that if there is something digital rather than human who can work with the medication itself, it was found that the errors getting really reduced dramatically and could increase the patient safety in patient and in healthcare. So what happened is the opportunity of medication error to be reduced. There is many examples of digital electronic systems that can be applied inside the healthcare system, so they can reduce the possibility of errors in medication management. So one of those systems, it's really a very important system that's supposed to be applied everywhere. That's from really a lot of studies and a lot of research talking about this system. The robotic barcode medication dispensing technology. This robotic barcode medication dispensing has to have a bulk store in the pharmacy and has to have a system, a software that can merge with the HIS system, which is the health information system of the hospital. So this merge, if there's an order entered by the physician in the system, the order will be translated and goes to the medication dispensing drawers and start to pick up the medication that's supposed to be dispensed for the patient and transform all the information on those labels. I'll show you my pictures. Those are software for barcoding, and this is the way of barcoding reading, barcode reading. So it's a very huge element of to be applied in each healthcare institute. But if it's applied, because it's supposed to be not to be only this one, it has another one, which is storage dose, which is the pill pick. This pill pick, together with this barcoding, will do a good system to cover the medication identification and this preparation, then dispensing. Actually, the IV medication, they do have also a software, not applied much, which is Riva, and there is another software, but this is not commercial. We're just talking about what's available in the market, but choosing those digital information and those digital systems supposed to be depend on the way it's very convenient in using, ease friendly user, and even financially and economically convenient. So actually, these are some of the obstacles that can happen inside the huge healthcare institutes because of their cost, and there is a lot of training, a lot of installation, and there's supposed to be an IT team to follow, and a lot of details to follow. But the medication storage unit, the one I just saw you, is a decentralization. Means if we do dispense the medication all from the inpatient pharmacy as the main inpatient pharmacy, the unit dose for oral, so it would be in every ward, like surgical ward or the medical ward or the ICU ward. It would be there to dispense from each ward. Instead of having a satellite pharmacy, we will do this pill pick cabinet that will be for each of the nursing, will use it by its password, and they will just take the right medication for the right patient with the right label to the right location of the patient. And this is really a good identification of that cabinet, of that patient medications. And even to also identify those medication dispensed for the patient, there is a system of barcoding inside the room of the patient and the patient bedside. So it's a wireless barcode medication scanning system. Use a three-way barcode check to assure that the right medicine is being delivered in the right dosage. So this will be to the right patient because it's on the side of the patient. Will read and will see this, will scan this kind of bracelet that has all the information and has a barcode even, and this is the barcode reader from the side. So it becomes a mandatory thing for the patient safety, but it has some challenges. Even the infusion pump, which is available right and left, these pumps really help to prevent harmful medication infusion errors. The medication infusion error could harm the vein itself. So they are mostly among the most common type of medication error happening is the infusion problems. So giving the patient the opportunity to have an infusion pump with a fixed electronic infusion rate could help the patient to survive without any vein damage or any peripheral side damage or pain. So really, it really helps. But most of the kingdom now, most of the hospitals in the kingdom, they're having the intravenous infusion pump, and that's really very effective to be used and very safe. The unit dose drug distribution, the other one, rather than pill pick, rather than the other, the one that I just mentioned, this is the pill pick that has a 90% of the medication stored in the main pharmacy, located in an automated dispense technology, use the barcode and eliminate the possibility of human errors. It's a whole room that has chambers right and left with many boxes inside, but it has a system to follow on the refill of medication inside, and then it will just give us the product that has the barcode of each, and those are bags covered with labels, each patient name and the medical record number and bedside and medication name on the label itself. And the other backside, it will be the plastic bag with the medication. So if this bundle, you will see it is a 5 or a 6 medication all wrapped in one bundle. That means all of those medications are going for one patient. The other way to just avoid any harm for the patient is the CPOE. CPOE system is a computerized physician order entry system that should come first in Safe Health Institute. This becomes really mandatory, and it has to be available in every single hospital. But for the meantime, the Kingdom of Saudi Arabia are towards digitalization. And most of the hospitals, the tertiary, specifically the tertiary hospitals that has research centers, that has cardiology, that has oncology, most of them, they have this computerized physician order entry. And it's really important in prescribing errors, reducing prescribing errors, and to avoid the bad physician handwriting. We, the pharmacy, we have really a bad history with all physicians' handwriting, but we can read it. We are keen to read it. Computerized decision support also is important. If we do have a database, a good database about medications like Lexi.com, like Micromedics, Databank, those are the one who's installed inside the HIS system, and the computerized physician order entry start to extract those data. What type of data that we are always looking for? We're always looking for the doses, proper dosing, in proper diagnosis, for the proper management, the proper frequency, the proper route of administration, the possible drug interaction, and the dilution and infusion rate of the IV medication. So the CPOE really giving the healthcare provider a good environment, of safe environment to dispense safe medication to assure patient safety while working on daily basis in our operation. And high-risk abbreviation is really elemented in those systems. The computerized physician system has nothing to do with abbreviation. It has, I didn't mean nothing to do, it has no abbreviations. So it has a very clear words in every single medication. All medication comes with different strength and different way of injecting those medication, and even the dosing. They give red flag for any wrong dose that it's chosen for a single weight for the patient. So it's really, really increasing the safety dramatically. So the loop, that's usually, this is the ideal way of doing patient medication management, starting from the CPOE. Then we will do the proper communication with the physician or nursing, just to make sure that there is issues about medication administration timing, or any issues regarding the timing of giving the medication. Then we will do verification of the order. Verification means reviewing the order from diagnosis side, from the drug interaction, from the labs if possible, and we do have the time and date of the order itself, and also the physician's privilege. Then we'll take this order verification to be dispensed through the automated unit dose system room. It's a room actually, because it has a huge machine inside those rooms. And then after dispensing those medication, take the bundle and put it inside the pneumatic tube, and goes through the air, through the tubes inside the hospital to the ward. Then the nurse will take the medication from her tube and check and verify and double check about the patient with the barcode, whether this is the right medication for the right patient, within the right dose, within the right time. for the patient and then start administering the medication. So here is the beauty of digital system that can help to increase the safety of the patient without any human errors that can happen. But the reality is, if we have a technology trigger, means if we do have an idea about the the new techniques or a technology digital thing that could be applied in the hospital, it has a very interesting and excitement environment. People will start to push that to the maximum. So there will be a peak of inflated expectation because people will support and they will start doing the communication. But there is some resources that some things that it's happening and some steps happening from financial point of view, from administration point of view, from even limitation of staff, manpower, and the training and increasing the demand on while installing those new technologies. So the peak will start to go down due to those obstacles, and it will go to a trough of disillusionment. Why? Because of the in and out of multiple obstacles that could happen. But it needs a strong, hearty people who can do a support to those digital things. So it depends usually on the healthcare administration and the stakeholder to start to do empowerment of those technology to be applied in each healthcare institute. So starting from this trough to with the slope of enlightenment, the plateau of productivity will start. So this is normal happening in each hospital. So this is happening with everyone needs to apply new technologies. So what we say about the CPOE and the unit dose technology and the barcoding are everyone wants to apply, but you will find something there in hospital X from those, and you will find in hospital Y another thing. Not all of them applied in one place, unless very few hospitals due to those obstacles that's happening, but which we are wishing that all the healthcare field should be to be digital, just to avoid any harm to the patient and the errors. So what we will do is after the peak, people in phase 3 will start to do, after the trough, people will start to do ideas of let's working on, let's refine it, let's improve the technology, let's do the research to demonstrate its value. So these are really the hoping staff, hoping stakeholders that can do support any healthcare institute who's willing to put the digital system inside their service and operation. So from the lane safety measure, we can do the best we can do is we have to begin asking our staff by survey. So usually a healthy culture to maintain safety, we can do a survey usually for the staff to take an annual culture of safety survey. Then the result will let us do an important steps in improving and give us an area such as a perception of our overall safety climate and the areas of teamwork and communication. And we will talk about this communication issue with the patient, which really affecting dramatically the patient response and the patient ability to take the medication and to follow the proper instruction and do not hesitate with going and coming with the physician himself and do proper communication. So prevent adverse drug effect, we should do have a medication error reporting system. So now we're dealing with the documentation. What is the importance of documentation? If there is no documentation, we wouldn't be able to check the international level in the US to see the amount of medication errors that happens due to bad administration technique or wrong administration technique. So internationally, we found that there is an estimated of 19% of medication administered in US hospitals administered by error. So if there is no documentation in those hospitals in US, we wouldn't take this number out from the research. And also, there is a 2% of patients admitted to US hospitals due to experience of harmful medication error. So to prevent this adverse drug events, we should have the reporting. So what is the medication error study saying? If we want to do among all the leading cause of preventable errors, we have an incident of 5.7%. That's what we had from the international standard. So whatever you do to a prevent to those medication errors, there's also another error. So you can believe now that there is a problem happening while even the system is there, but it's just human errors sometimes. So there is a study talking about the preventable medication error by Koshal, Bates, and Landergan et al. In 2001. Since then, it was talking about there is an approximate $5,000 savings per event to reduce the preventable medication error. And for a 700-bed hospital, there is a $2.8 million saving just for preventable medication error. So unsafe medication practice, it has three main criteria. Three main causes. So poor access to information, which is the patient information himself, the medication information, and the file information, and the nursing information. Poor access to information, which I cannot read the progress note, I cannot read the nursing note, I cannot read the pharmacy note, I cannot read the physiotherapy note. Poor access. So digital information could do the job. The second thing, poor communication. If I did not do a proper communication with the physician or the nursing or the patient due to limited time, overload of work, I do have bad communication skills. I do have good communication skills, but I'm not focused. There is an issue with the communication. So if I did not do a good communication, I will talk about it now, we will just go in bad medication safety manners. Inadequate knowledge or experience, which is really a trouble that's happening in the hospitals, that they don't do proper training for their staff. They don't do proper competency checking of the patient, competency checklists doing by the managers or by the superiors to do a proper competencies of their staff with the work elements, and to check whether they're working with a good quality standards or bad quality standards, and they have to have an evaluation and according to that. Medication administration is one of the things really identified by risk management as areas of concern in healthcare. So the legibility of the physician order means how can we read the physician order? So being able to be read well will be a good for the medication administration. Administration is being good. It's a thing that it's handled and responsible by the responsibility goes back to nursing. The administration goes back to nursing. So if the nurse reads well and the pharmacist reads well, and the one who is transcribing the order is reading well, so the medication will go with a proper infusion period, with a proper dilution and the proper administration technique. Also, the way to read the addressograph information, which is the information of the patient contact or the patient identification. We do have patient name that has three names, the first and the father name and the family name. And we do have the medical record number there. And we do have the location of the patient. And guess what? One of the words I was working in, I found 3 Noura al-Ataibi inside the word. So if I did not have the medical record number and the right location of the patient and the middle name of Noura, that will be a trouble for the pharmacy to give the medication for the word, and trouble for the nurse to identify the patient herself. So really, it's an issue that we should follow in identifying the patient. Complete the physician order by doing the 5 patient rights. I will talk about the 5 rights and the 10 rights. 5 of them related to the medication, and the other 5 is related to the patient rights by himself. And also the automated medication administration record should be filled and will be readable, good to be readable by the physician. So the order will be good and I can read it. And the MAR, which is the medication administration record, that every medication given to the patient is written there by the timing, by the dose, and by the nursing name. So there I can check as a clinical pharmacist the name, the medication, whether when it's given, and I can check the peak and trough, whatever antibiotics I can take, and the physician also can check what about the PRN medication, the heparins when it's given, whatever the enoxaparin, whatever. So the communication issue. If the doctor and the patient has a proper communication, consider the patient has a medication safety, he is safe in safe environment, because he's going to have a good medication understanding. He will good have a patient counseling. He could have a good adherence to the medication taken by the physician, given by the physician, and taken by the patient himself. So quantity and quality of health information provided by doctors, it directly addresses the cognitive needs of the patient and or the parent, and the forms that the foundation of the physician task-related behavior. So whatever the physician is given from care, there is going to be a good digestion of the information about the medication, about the treatment plan, about the risk management, and the patient will start to be adhere to his treatment plan and proper treatment. So what we have here is a nonverbal way of communication that we should respect, and it's supposed to be maintained well, because sometimes the eye contact has a problem with using with the physician. If the physician is always not looking at the patient, or having a problem that he's nervous and he's looking in a way that he cannot be sincere and giving full care. This eye contact is very important to show the care. Even the appropriate gesture, if the physician is sitting and he's not, he's anxious and he's keep his arms in a position that it's not showing care, or even is ignoring the patient available in front of him. And if the physician is talking fast with an attitude that has a problem, this is going to be, excuse me 1 minute, please. Sorry. So this kind of nonverbal communication could do really an impact on the patient absorption of the information about his treatment plan, about his medication to be used, and the compliance. And this will jeopardize the patient safety dramatically. So from this, we can tell that we need to have good communication with the patient, even the child. I've read a lot of literature talking about the communication with the child himself and his parents, and that will really develop a good relation that makes the family happy to do the treatment, specifically in the chronic disease, diabetic patients, paralyzed patients, epilepsy patients, those kind of pediatric illness, that makes the parents really happy to have good care and good communication with the physician to do proper management for their child. So the communication skills can help the patient in doing venting their feelings. We can listen to them as a healthcare provider, listen enough to show the empathy, and we really show care and give them some time to talk. and also strengthen the communication skills by the physician, that he is a teacher or a coach. Even the clinical pharmacist, when we do a patient counseling of proper medication use, and I will show you a sheet that we usually communicate with the patient, and we write down some things in Arabic and some medication names in Arabic, just to make sure that the patient understands what he is taking, why he is taking it, when will be the proper time, before food, after food, at the end of the night. Is it will cause a drowsiness? Is that the patient will be should not drive while he is taking this medication? When he's supposed to come to the ER? What the type of things that he can feel and makes him come to the ER? And the physician should have a good history from the patient and even the clinical pharmacist, asking about the medication that he is using before. That's why we're always asking the patients to come with the medication bag to our place. Why? Because sometimes the same medication is given twice from two different companies, and the physician and the patient is taking the same medication twice because he don't know that the same amlodipine is coming from this company X and the same amlodipine is coming from this company Y. So what's happening is that we need always to take a good history of the patient use of medication to avoid duplication and to avoid patient to be in risk of having severe side effects and toxic level of medication because of ignorant or illiterate patients who cannot read. So we make sure, we pharmacists, that from patient counseling, we make sure that we take a good history and we give good counseling. And from the physician side, and even from the nursing side, everyone should take a good history so we can have a good communication with the patient, just to make sure that we have a safe medication environment. Try not to judge the patient. Usually we have opportunities to give the patient some time to talk, and we should not judge them. We should remain calm and confident if they shout, because sometimes patient comes angry, depressed, manipulative, sometimes seductive, and sometimes overly dependent. So we should understand our strengths and vulnerabilities, which is نقاط الضعف. We should understand that there is a limit for each patient to talk, so we have to have a border between the patient and us with a very professional way and very sincere way. But we should not be burned out by giving an extra care while there is a possibility to have a good level of care without harming the patient and increasing the outcome of patient safety. So respecting the patient, and we should be patient with him, is one of the demands in our work from physician side and from pharmacy side. We have also something that can obstruct the communication. We should have multiple body system to convince the patient. Sometimes the patient give vague information, that sometimes the patient has minor symptom and keep talking and talking. Sometimes the patient have a poor response, and we started to have a method of treatment that we should change it due to the poor response, and there's this hostile and demanding and dissatisfied patients. So what we do usually, we just increase their care plan involvement. And the medication error that we do have is types of medication error that has as mistake in the prescribing, dispensing, administration of a medicine that could cause harm to the patient. So worldwide, most medication error occurs during the administration stage. We're not criticizing nursing, but what's going on, that there is a problem from the medication verification and prescribing from the pharmacy, and give wrong information to nursing. And there is a wrong way of doing double checking from nursing side. So it's a one-to-one situation. What we have also is from prescribing, transcribing, preparation, administration. So those are the types of error that it's happening due to medication management. The wrong drug or dose, it can be corrected by double checking. the transcribing error, the one we do a label. Whenever we do a label and calculation, there is some errors that could happen, and also the preparation technique due to wrong calculations could happen with also a bad calculation without checking from the assistant pharmacist inside the area. Also, the administration error comes from the wrong calculation that comes with a wrong label, comes to the nurse without double checking and giving this wrong time, or omission of doses, means removing the dose and the patient refused to take it, or the nurse forgot to give it or forgot to record it. So those kind of errors that could happen, but there is a factors usually affecting even the medication action. If we don't do errors, we should consider the pregnancy and the infants, because whenever we want to dispense medication for the safety of the patient, if the patient is pregnant, we have to check the level of category to be whether or not to be, either whether this is a category A or B or C or D or X. The category A and B are the safest, but when it comes to C and more, it will be very risky to or teratogenic to the pregnant. The infant even, we should usually, because their immaturity of their organs, we should consider the doses that given to the infants to be very safe and be within normal range upon the information, the drug information. The adolescent, which they are between 12 and 18, they're not adult, they're not pediatric, in the middle, and we call them al-murahiqin. Those adolescent, they do have this high doses that can be given, but the problem is that the body surface area of the child or the adolescent is a very risky body surface area that we cannot omit. We have to follow the quantity that should be given per each kilogram of those adolescent, just to avoid any toxic doses that can be given for those puberty stage population. Even in the geriatric, we should not give the same adult dose to the geriatric or the old age patients, because we have a different response of medication due to their multi-organ stress. And that's not failure. Stress means they are overwhelmed and they're having a lot of diseases that could increase the liver enzymes, that could deteriorate the kidney function. So we should consider the doses. Also the gender, if we do have a male rather than a female, if we give a medication to a male, that's supposed to be in a different distribution effect because of the muscular distribution in the body of the male, and also in the female due to the fat disposition. So we should always check the quantity of medication that's given in the fat disposition and in the quantity of muscles and proteins. So the blood component is an issue, the body surface area is an issue, the fluid compartment, because even the quantity of fluids that's given to the male is really a higher quantity than the female. Hormonal differences also is an issue. What we have is we do the hormonal differences. We should consider these hormonal differences is an issue because sometimes the hormones of the male and the female has a problem, while we give a medication that has a high estrogen-like symptoms, and it can be given for a female. So those are the difference that affecting really the administration of medication and also the time of administration. And this is really a huge topic that we always make the people understand, and we teach these topics to them. The topic of administration, which is the time of administration, we should be very careful when we give medication to the patient about the timing. The frequency affects the timing directly. How can we give an every 8-hour antibiotic without knowing that there is a fixed time to be given to this patient? The fixed timing of the first hours, which is the every 8-hour medication, supposed to be 1400 time, 2200 time, 6 a.m. time. If this is a fixed way of frequency, we will do the same medication administration time with nursing. We will teach them that we do have our specific administration time for the medication that they should follow. And if the medication is fall in between, we should do a catch-up policy that they're supposed to follow. So the time of administration is an issue for the IV medication specifically, and it has directly effect on the therapeutic action to avoid any bacterial resistance that could happen while reducing the dose or increasing the time between the doses of any antibiotic that could do a real serious resistance of the patient, and the patient could be harmed with many antibiotics. So for this, we have another effect on the medication, which is the environmental temperature, and the patient, even if he's taking sedatives or analgesic, the patient have to have a good communication with a good quantity with a good management of medication, just to let him understand that what the risk of his medication and this sedatives, and just to avoid this kind of harm on the patient. The physiological factors can be different between a patient or another. The illness and disease can be different from patient to another, because the three major organs, which they are the heart, the liver, and the kidney, if they do have a physiological problems, we do have to alter the medication due to these illness of those major organs. And the time of administration was already discussed. Also, the medication counseling that's supposed to be have to have a certain elements be given to the patient, name and class of the drug, and the common important drug-drug interaction, drug-food interaction, and the timing of taking those drugs and what is the importance of them. So they are an elements that's supposed to be followed, and this is the sheet that we write for the patient, medication name in Arabic, and the way to take it, and what is the effect of each medication. And this is happening for the 4 medication and above for the patients. So that's what we do usually to maintain the patient rights. We do have right patient, which we're supposed to identify, right medication, right timing of the medication, right dose, right route, and the right information of the drug patient education, right to refuse the medication by the patient, right assessment by the physician himself, right documentation to be done for the patient after dispensing and before dispensing, right evaluation, and to be measured fully. So that is exactly what we want to deliver today about patient safety. Hope my presentation was light and informative, and we can take some questions for the meantime, and I will be stopping now.
Thank you, Dr. Amani, for your wonderful presentation.
Thank you.
We have 2 questions. One from Iqbal. She's asking, if I have a medication error, what is the process I have to do step by step?
Okay. Is it Iqbal a male or a female?
Well, actually,
because it's both. Okay.
Let me
talk
both.
to, huh?
I said it can go both. I don't know.
Okay. Okay. Iqbal, what we usually do for medication errors, what we do a documentation, we do have a form that's supposed to be filled by the error, who already discovered the error, whether from pharmacy or from nursing or from physician or from any of healthcare providers. They can dictate all the error inside this form, and it's supposed to be categorized in the same form, whether it's category A or B or C, means it did it reach the patient or did not reach the patient. And there is also a guidance to categorize the error. Then there is a medication safety officer available in each ward, in each pharmacy. And this medication safety officer, usually when we have an error, we send it to the quality department through the medication safety officer. What's happening, the quality, they categorize the errors and they send whatever to pharmacy. The pharmacy will review and will start to analyze why this error happened. And then the management they will start to do root cause analysis. They analyze the error and they start to do kind of a studying. What was the cause? Is it because manpower? Is it because malpractice? Is it because of lack of training? Is it because of the system? Is it because of what? And if the cause is there, the medication safety officer will do a kind of collection of all the causes, all the errors happen, and start to share with the pharmacy department in an official presentation with an official email. So that is exactly from step A till step X. The second question, please.
Thank you, Doctor. The second question from Hassan. He's asking, as the list of HAMs are different, what is the most perfect list to be followed, which is accepted by the ESR standard in hospital?
Okay. The chapter of safety in Sibahi has their own list of HAM, the high alert medication, okay? And the list of HAM now are updated upon the World Health Organization, and it's available there as a site. So you can just go and just take it. But if you want my advice, this list have to be shared with nursing and the pharmacy, and it have to be available in a designated area. All the medication that is related to the HAM, especially the anticoagulant and the anti-diabetic medication and the inotropes, they can all be in one place. And if you have chemotherapy, it have to be available, but it's in a designated cabinet also. Then this list have to be followed with a good training, how to handle the high alert medication and how to prescribe, how to do kind of verification, how to do transcribing, how to do double checking, independent double checking. Then when dispensing to nursing, we have to have a small label on them that they are high alert medication. Because if the nursing, they did not know, they won't do the proper identification of the medication, so they won't do proper safety measures to avoid any patient harm, because there is a specific harm if they don't catch a mistake in this high alert medication. So they're supposed to have a 2 independent double checking from nursing. That's it.
Thank you, Doctor. I think we have 3 more questions. One from Ahmed. He's asking, as you said, for high alert medication, we need to double check. And sometimes, especially during night shift, there is one staff nurse. How can that nurse do the double check?
That happens mainly in most of the hospitals. But what we do usually, after we do the label, we keep the label on the side and then we come back to check again. That's the issue. I am, as a staff, I do the double checking twice. First, I do the label because sometimes the nursing is the one who's preparing the high alert. If they're preparing insulin, if they're preparing heparin, if they're preparing any of those medications, it can be given in the night. But if she started to do heparin and do the calculation, she can put the label and start to do kind of verification after doing the calculation. Then she goes back to the order versus the label, double check, and then give it to the patient. That's the way we do if we do have a one staff only before administering. And that's why they admit in most of the studies that the problems of medication errors coming mostly from administration. Why? Because of lacking of double checking. But I can do a double checking on myself, but at least I have to have this kind of feeling of incorrect. If you have a self-confidence, you do it yourself in home with your family. But in work, you should always be suspicious about your work. So you can do a proper double checking before injecting the patient.
Thank you, Doctor. So we have Ghada, she's asking how we would convince the hospital management to transfer to automation solutions, especially if it's a private sector.
Usually the private sector are following Sibahi standards. And now we are starting to do kind of audit on the big hospitals that has 300 beds and above as a tertiary hospitals to have automation. this automation, it will be costly, but on the long run, it will be very safe, effective, and very economic, because it helps to minimize manpower, minimize medication error that could do an increase in the cost due to medication errors and physician or nursing or pharmacist mistakes. So this could increase the hospital stay due to errors. So that's why automation becomes now mandatory, and they're trying to apply it to all hospitals in the kingdom, from the governmental sector to private sector.
Okay, I think we're short in time. We will take one last question from Ahmed. He's asking, who should classify drug reaction, if it's allergy or ADR, and the severity of this reaction? Is it the attending physician or the pharmacist? And sitting don't have a medication safety officer.
Okay, the adverse drug reaction can be noted in the form by any of the healthcare providers who is dealing with this drug, because the most the most common adverse drug reaction reported by the nursing, because they are the one who's giving and administering the medication. And whenever you report it, immediately it have to be sent to Drug Information Center, not the medication safety officer. The Drug Information Center is the one, they are doing the communication with the higher authority from the, let's say, from the hospital administration, just to inform that we do have an adverse drug reaction that will be discussed inside the Pharmacy and Therapeutic Committee, whether to increase the safety by doing kind of allergic testing before giving this medication, or to go on with the practice matching the international standards. So it's discussed upon the Pharmacy and Therapeutic Committee that is available among the hospital, and it's reported by the one who did discover it from nursing or physician. And the one who is taking this is the Drug Information Center that is available in the pharmacy. So it's a multi-disciplinary team action that could help in reporting this adverse drug reaction.
Thank you, Dr. Amani. I will take this opportunity to remind the audience about the upcoming webinars that's aligned with the World Patient Safety Day. And you can go to the SBSC webpage to view and submit to this webinars. Also, for the National Patient Safety Award, 5th National Patient Safety Award, the registration is open. And you can go to the webpage, also on the SBSC page, and the deadline for registration is on the 13th of September. So this is the end of our session today. On behalf of Saudi Patient Safety Center, we would like to thank Dr. Amani Bahdela and the audience for their active participation. And we would appreciate if you would fill out the evaluation survey sent to your email after this session. Thank you for your joining today, and we will looking forward to welcome you back in the future webinars.
Thank you very much. Bye-bye.